This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. Content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everyone. We're here for another episode of the Not Your Doc podcast. I'm your host, Vanessa, and we're here today with Mr. Not Your Doc himself, Dr. Charles Tadros.
Hey, Vanessa.
Hello,
Hi,
Dr.
Seth.
Tadros.
Hello. Oh, am I supposed to talk?
Yeah.
Yes, you're loud.
Thank you.
I'm a little loud. I'm sorry. I was so concerned with your mics, I forgot
that's
about
very
mine.
nice of you to think
I don't
of.
have anything to say really.
Well,
you're
welcome.
the subject matter expert.
Welcome anyway.
Well, thank you.
That's our producer, Seth, from Benton Park Media. We're happy to be with him as always. We are on episode 6 of this second season of the Not Your Doc podcast. It's pretty exciting that we've come this far.
Yeah.
Today's topic, I think, is a good one. It's another condition that is, certainly relevant today, being talked more about. Our last couple of episodes have been kind of about chronic conditions that, take up a lot of time, resources, energy in the healthcare system to get treated, stomach issues, back pain. And so we're going to go with another pain disorder today called fibromyalgia.
Yep.
And so fibromyalgia is characterized by widespread pain, fatigue, and cognitive issues. And it often overlaps with other physical and mental health issues. Similar to IBS, it's kind of a constellation of symptoms that can be, confused with other things. And the true diagnosis of fibromyalgia is arrived at by sort of eliminating all of these other possibilities and then arriving at it. So interestingly, fibromyalgia is not an autoimmune or inflammatory disease. And so it's unique from other conditions that cause widespread musculoskeletal pain like lupus or arthritis that we've heard of. So this is going to be a really interesting one today. I'm looking forward to hearing Dr. Tadros talk about it. I'm going to start with, as we like to, with just a little bit of context about the problem, the epidemiology, if you would like, about fibromyalgia, how many people it affects, what kinds of people. So my source for these next few facts here comes from a 2022 literature review in the National Institutes of Health. A literature review, by the way, is just a survey, a wide overview of lots of different resources and studies, a body of work, and then that's published in a scholarly journal. So that's it's right. Kind of an overview, kind of aggregates a bunch of information together. So fibromyalgia affects about 6.4% of the adult population in the United States. And while there's not really an exact number of people known to have fibromyalgia, the rate for adolescents, according to many studies, seems to be about there as well, 6.4%. Interestingly, it seems to affect women more than men, similar to IBS. And fibromyalgia is found to be the cause of widespread generalized body pain in most women between the ages of 20 to 55. So kind of excluding other reasons, it's typically fibromyalgia for that widespread chronic pain for women in that age group. Also, fibromyalgia is typically triggered by some sort of medical or psychological event. Dr. Tadros is going to talk more about that. And then finally, among patients referred to a pain management specialist, 40% met the criteria for fibromyalgia. So this is really impacting a lot of people, accounting for a lot of doctor's visits, and of course costing a lot in resources, both, direct and indirect costs associated with missing work, paying for doctor's visits, paying for treatments, and of course just a lower quality of life and productivity for people that struggle with it. So, Dr. Tadros, we're talking about a condition that affects many people across a wide range of ages. Can you start by helping us understand why it seems like we're hearing more about fibromyalgia recently?
Well, thanks for bringing this topic up. Wait a minute, I'm the one that
Wait,
I'm the one that asked you to bring it up. No, thank you. it wasn't until much later that I recognized that my mother had fibromyalgia, and because it tends to run in families, I have it too.
Ah.
So it's very personal. So fibromyalgia, we can come back and talk about how we got to this name, but fibromyalgia or fibromyalgia syndrome (FMS) is a pain syndrome that's more neurologic, even though it seems to be in your muscles, and it feels like maybe the tendons that hold the muscles to the bone. It seems to be tender, what we call tender points. What happens is that this is a chronic pain syndrome, and whenever we do biopsies of muscles and skin and tendons, there's no destruction, and it doesn't cause pain in joints. I don't know, some people think everything hurts, so pain in joints. It's not really a joint pain problem. So it turns out that's really a chronic. It's a primary. It means we don't know the actual cause, but it's a primary pain syndrome, primary chronic pain syndrome, and it seems to be part of the central nervous system. That's where all pain eventually has to go to be interpreted. Your spinal cord eventually up to your brain for you to feel it. But we've certainly had it for many years. It's only by about 1990 that the American Rheumatologic Association came out and made criteria for it. Back then, it was tender points and some other things. We've taken away the tender points as a criteria.
Sure.
But
the number of tender points.
That's right.
Right. Yeah. Okay.
That's right. And the word tender and trigger are points are two different things, and I'll come back to that. But really, it turns out that we probably had it for a very long time. We've just been able to, because you're right, it's a syndrome, because it's a collection of symptoms. And there's no test, there's no blood test, there's no brain test that perfectly defines it. Some people came out a few years ago and showed a vibrational spectroscopy of blood tests, and they showed that they can differentiate these fibromyalgia patients from rheumatoid arthritis patients and lupus patients. But so there is some research out there that's trying to find a simple blood test that you can help catch these people sooner.
Sure.
But it's probably been around for a long time. We just finally put it together and put it under criteria and under the rheumatologists essentially. But these people end up seeing a lot of different specialists, and so we'll talk more about that too.
Yeah. Can you say a little bit more about, I know you said we think it's a neurological issue, maybe a pain regulation disorder.
That's right, it is.
Can you say more about how that's distinct from something like autoimmune like lupus or rheumatological like arthritis?
Yeah. When we talk about, whenever my mother or I have arthritis, or somebody says they trashed their knee playing football in high school, or they were a gymnast and they have arthritis many years later, that's osteoarthritis, a degenerative arthritis. It's a wear and tear arthritis. It's not an inflammation that destroys. It's not your white cells and your antibodies are not going in and destroying a joint. So the joint destruction arthritides or arthritis, the joint destruction ones include the ones that you already know. These are inflammatory arthritis. These are rheumatoid arthritis and psoriatic arthritis and lupus and multiple other ones. So mixed connective tissue disease. There's a bunch of other ones that cause destruction of joints.
Okay.
But the general arthritis most of us get, our knees, our hips, in our hands typically. Often these are osteoarthritis. You'll have a grandmother or somebody who has very severely deformed hands, and sometimes those are osteoarthritis, but sometimes they're rheumatoid, and rheumatoid is that inflammatory class of arthritis. Well, fibromyalgia doesn't seem to be degenerative. It doesn't seem to be like osteoarthritis. It doesn't seem to be inflammatory like lupus and Sjogren's and rheumatoid arthritis. So it's its own class, and because we feel it in our musculoskeletal area, we went looking. People thought, well, surely there's some sort of destruction, some sort of inflammation, but they biopsied and they just don't find anything. So it seems to be the interpretation, your body's interpretation of pain without any obvious cause for the pain. But like you mentioned, there may be triggers that cause people to slip into fibromyalgia. There seems to be genetic tendency, like it runs in my family, but also some of these people who are under a lot of stress, who are having depression, had some sort of trauma, physical trauma like car accident or emotional trauma, abuse and stuff like that. There's a ton of associations with fibromyalgia, and we'll talk a little bit more about that.
It's interesting how fibromyalgia is so distinct from these other things, I think logically, as like a non-medical, just layperson, I think if something hurts, there must be a visible cause for what's causing the pain, right? So as you're describing, osteoarthritis and rheumatoid, it's degeneration, breakdown of the tissues and the ligaments, the things that lubricate those joints, that is causing that pain. Whereas fibromyalgia, we think, is more about the pain signals that the brain is getting.
Is misinterpreting. Yes, that's correct.
Misinterpreting. So the pain is very real. It's very much felt. It's very much
it's very disabling.
Embodied. But it doesn't have a physical source in a degenerating bone or muscle or tissue group.
Or nerve, even degenerating nerve issue. That's correct, like neuropathies. Some of our patients come to us saying, I have a neuropathic pain. And we typically think of neuropathic like a peripheral nerve, like a diabetes that affects the nerves to your feet. Or after shingles, the virus comes out through the nerve and destroys the nerve, post-herpetic neuralgia. But yeah, these peripheral nerves don't seem to be affected. We believe it starts potentially in the spinal cord and some of the support cells, the glial cells that may be supporting the nerves that may be involved in some of this misdirected pain signaling, this persistent pain signaling when there's no obvious injury, no obvious harm. Typically, we think of pain, especially acute pain, as warning you to stop.
Yeah.
If your hand, you wrenched your ankle, you burned your hand, there's immediate pain to pull back and stop, to hobble, to sit down, to pull back your hand and not put your hand out where the flames are again. So it's very protective. But there's nothing that was obviously physical. That some people had a virus and some people were abused physically. There's no doubt there's some things are physical types of traumas. But the pain signal and the perception of pain, that what we call central sensitization of pain, persists for years after potential minor or practically no insults to your body. Yeah,
that's interesting. How it with fibromyalgia, it's almost like, like you're saying, typical pain is protective. It's a protective instinct to stop something that's damaging.
Absolutely.
So we typically trust that response in ourselves.
That's right.
and think it's working that way. So I'm drawing a parallel to, mental health issues where we use our emotions a lot of time, or our instinctual and visceral responses to guide us for some useful thing.
Right.
And sometimes those pathways, those messaging pathways get messed up and we can't trust them all the time.
That's correct.
So it works with pain as well as with mood. That's very interesting.
And this is especially brutal because the more you try to do and the more you try to be active, the worse your pain gets.
Yeah.
So it kind of punishes you for trying to do the right thing, which is at least initially, which is very frustrating. It's just very disabling. It puts marriages at risk. It puts people that probably 25% of these patients that have chronic fibromyalgia, oftentimes they have a bunch of other things going on also, but they're 25% of them may be disabled, literally social security disability. So it costs a lot. It hurts a lot. It affects your mood. It affects your sleep. It affects so much stuff, your ability to make money, your ability to help out with your family.
Yeah. Huge quality of life impacts.
Yeah.
Can you say a little bit more about what fibromyalgia pain feels like?
Sure. Yeah, I could experience, So we describe it, and it's in my blog also. There are a couple of ways people describe it, and sometimes it sneaks up on you slowly. It starts in one part of the body and then spreads. So let's define it. It's a generalized pain. It's a diffuse pain. It's not just in an elbow or a shoulder. It may start like that, but it becomes diffuse. It means all over your body. It tends to be symmetric. Your shoulders hurt and they ache, or your thighs or your calves, and so it's symmetric above the waist and below the waist, and on the right side of the body, left side of the body tends to be symmetric. And it's a diffuse all over pain, like I said, of the muscles, tender points. So that's kind of how we start. Typically, you have to have the pain probably pretty much every day for at least 3 months.
Sure.
So pretty much every day, a good chunk of every day for 3 months. And it tends to be associated with other things that tend to be other qualifying factors. It tends to cause fatigue, so that you wake up, you're already tired.
Right.
That's probably related in part to non-restorative sleep. So you have disturbed sleep. You have a hard time dropping off to sleep. You pop awake throughout the night. By the way, that's what we see also with anxious and depressed people. Anxious people tend to have a hard time dropping off. Depressed people can be popping awake throughout the night or wake up too early in the morning and can't get back to sleep. So this is going to overlap with a ton of other chronic diseases, and that's an interesting piece of it because it's neurologic, essentially, this problem.
Sure.
These people oftentimes have associated irritable bowel, spastic colon. We just did a talk about that. These people can have dysmenorrhea, painful menstrual periods. They can have dyspareunia, painful pelvic pain with sex. These people can have jaw pains, like you see with TMJ, temporomandibular joint syndrome. These people can have headaches, both muscle tension headaches and migraines. These people can have all sorts of other things, light sensitivity, smell sensitivity. And like I mentioned before, whenever these people try to exercise, weight lift, run, swim, it hurts. And in fact, if they can do it for a certain amount of time, they feel like they can't go back and do it the next day. They can't keep working out. Their pain tends to go super bad. There's, once again, like we mentioned, there are no fevers, no chills, no joint swellings, no rashes, no blood tests that are abnormal, no CAT scans, no X-rays that are abnormal. If you do find a CAT scan or X-ray is abnormal, oftentimes it's a red herring. It's like we X-ray your top of your shoulders have been achy. We X-ray your neck and your shoulders, and we see arthritis. That's not the cause of your achiness. We just happens to be there, osteoarthritis or other old injuries on top of your fibromyalgia. It's not the cause for your fibromyalgia. Yeah. So the other thing which I had to read about, but some of these people have something called interstitial cystitis, which is a bladder, your urinary bladder, and your pelvis. Some of these people feel like the urge or the burning whenever you pee, or the frequency. You have to keep going back. You empty your bladder, you get up, and you just walk away, and you feel like you have to go right back, or a few minutes you have to go back. And these people, if you check their urine analysis, oftentimes it's very normal or nearly normal. You have a cystoscope up to look in your bladder, and oftentimes it doesn't look very, you don't see much, or there may be a little bit of inflammation. You biopsy, there may be a little inflammation or nothing. These people are also at risk for having concurring fibromyalgia.
That's very interesting.
Yeah.
So it's almost like the volume on those pain receptors is
Absolutely
turned up really high, correct?
That's right. Yeah, it's either the volume on the pain receptors or their interpretation in the spinal cord and the brain. That's correct. You are correct.
Yeah. So who does this affect? It definitely seems like it affects more women than men. Are there any theories on why that is?
Well, we don't know. Unfortunately, women get to bear children, and unfortunately they get all this extra stuff that men typically don't have to put up with.
Right.
So unfortunately, women tend to have more problems with migraine headaches, more problems with interstitial cystitis of the urinary bladder. They have, of course, pain with sex and painful menstrual periods, and et cetera. So and they have more autoimmune diseases, more lupus, more Sjogren's, more scleroderma, more rheumatoid arthritis. So these women, God bless them, because they put up a ton. Whenever it rains, it pours. And
is there any thought that the frequent hormone fluctuations that we go through our lives has anything to do with that?
Certainly, we certainly see that with everything from fatigue to depression that swings with PMS and PMDD, perimenstrual syndrome and perimenstrual dysphoric disorder. PMS is milder, PMDD is more major, essentially. But yes, it may be hormone related. More interstitial cystitis, more bladder issues can also be related to hormones. And sleep disturbances certainly with hormonal changes, with hormonal swings that are natural part of the cycle every month. Right. So we don't fully understand why, and I'd have to see if postmenopausal women, if you had it premenopausally, once you go through the change, if your fibromyalgia improves, I'm not so sure it does. I've not seen it in my practice.
Right.
And certainly my mom, who was most postmenopausal at the end of her life, had severe fibromyalgia, and she still had it. Yeah.
Wow. Okay, so let's talk causes. So we can't pinpoint a specific cause for every person, but it seems sometimes that physical or medical events or psychological events and stress can trigger fibromyalgia. Can you talk more about that?
So for whatever reason, and we see problems with everything from migraines to muscle tension headaches triggered by trauma, physical and emotional trauma. We see depression, autoimmune diseases triggered by trauma, post-viral, post-emotional, post-physical trauma. So there may be a significant and even worse things. People who have inflammatory bowel disease like Crohn's or ulcerative colitis, if they have stress for a test, if they're a youngster, both men and women, they'll have flare of their inflammatory bowel disease. It's not because they've missed their medicines or anything else or changed their diet. So stress turns out is probably a humongous, really big cause for a bunch of problems that are related to everything from mood to sleep to autoimmune to heart disease, and certainly even blood sugar control. So we have there's probably a large component that we're going to discover now that we have the human genome ferreted out, and we're talking about proteomics, that we're going to be able to ferret out more what the biochemical changes are. With understanding more of some of the connectome, our brain connections, we're going to start ferreting out these things. So I'm very excited. These are terrible diseases to have. None of the fibromyalgia is life threatening,
right.
But boy, it's kind of life ruining.
Yeah.
But it's going to be
Altering,
very interesting to see what happens in the next 5-10 years. And we'll talk about some of the treatments and stuff like that.
Yeah, absolutely.
But yeah, it seems like traumas, and it doesn't have to be, it seems like traumas is one of the issues. We see the same thing with autoimmune diseases. We'll see that people will have a very difficult time at work or whatever else like that. They've done it a dozen times, hundreds of times. All of a sudden, one time, they'll just kind of feel beat down.
Yeah.
All of a sudden, they'll get more colds, more respiratory infections, and their belly hurts, and all of a sudden, they'll start having inflammatory bowel stuff that we later diagnose. Their fibromyalgia kicks in. Certainly, my fibromyalgia kicked in a few years ago whenever I was going through a tough period, but I've done thousands of tough periods throughout my life.
Sure.
So I don't know why it happened then, but the epigenetics, I had the genes or the genetics, but the epigenetics may have kicked in, or penetrance is what, so it expressed itself, the genetics, and we still don't understand the genetics either.
Yeah, that's interesting. So can illness or injury be a trigger as well? So when you say stress, that's everything physical,
Right. That's right.
to emotional,
Right.
psychological stress.
Infection,
Okay.
inflammatory, absolutely, yeah.
Any of those things.
Yeah, absolutely. And what's difficult is that the people have had stress many times before and done fine, or but they never had these persistent pain syndrome, this persistent central sensitization, central nervous system sensitization for his pain. So it comes out of, he feels like it comes out of the blue, and people don't know, they misinterpret it. And this is another thing we should talk about in another podcast. I find that people misinterpret whether it's depression or hunger or tiredness or fatigue, which means you start out fine in the morning, but you fatigue out more easily, or depression, viral syndromes. All these things tend to share similar physiologic sensations, and people misinterpret it. If you tend to be depressed and you feel like, why am I so cranky? Why am I so? And then a few days later, you're having a sore throat and fever, and you're like, and then that clears, and your depression seems to lift. Well, it wasn't so much depression; it's that you were coming down with the virus, but you misinterpreted the viral infection symptoms as depressive symptoms. So what I find is that people don't understand their bodies very well, and then something sneaks in like a viral infection or inflammation of their fibromyalgia, and they feel like crap, and they come to see me, and we go hunting, and we find that they were stressed and they had a flare of their fibromyalgia more than that they have a new cancer or anything else like that. Yeah.
That's interesting. Yeah, I look forward to revisiting that, because I know that being able to name and explain is provides a lot of relief and empowerment.
Absolutely.
And helps to rule some things out. So I know, let's talk about diagnosis now. I know you mentioned before that it's got to be widespread pain for a certain period of time to meet the diagnostic criteria. Right. What else is involved in diagnosis?
Yeah, so oftentimes this is constellation or syndrome. So oftentimes they want to make sure there's nothing else going on. You don't have rheumatoid arthritis or lupus or anything. It's pretty easy to eliminate. Typically you'll get a comprehensive metabolic. We'll be talking about this in another podcast. We'll get a complete or comprehensive metabolic panel, look at your blood sugar, kidney, liver functions. They'll check a CBC, complete blood count, to look at your white count, your red count, and your platelets. They'll check a sedimentation rate, if it is so just a generic inflammation marker. They may check a CRP or C-reactive protein, another inflammation marker. They'll check a rheumatoid antigen, a rheumatoid factor, and another factor called cyclic citrullinated polypeptide. There you go, CCP. They'll check an ANA for lupus and other autoimmune problems. And that's typically enough, plus your physical exam, plus your history, plus your physical exam, plus the test that I just listed. Yeah. Now, if anything more specific, if you're having belly pain and losing weight, they should do a CAT scan or colonoscopy, so some other things if it's more directed. But that's typically what you, so you want to make sure there's nothing else going on that could potentially make you feel tired and achy, et cetera. So the other thing that goes with it oftentimes is sleep disturbances and this fibrofog, this cognitive fogginess, slow. It feels like you're walking through mud and thinking through mud. Mm-hmm. So that's the other thing. So those are typically the big things. And then, like I said, there are other things that often are associated, not necessarily cause, but associated, that include premenstrual dysphoric disorder, pain with sex, depressive symptoms. They can have headaches, both muscle tension and migraines. They can have jaw pains, muscular, the masseter muscle, the big muscle, the big jowls, the stuff like that could be tender. So a bunch of those things are oftentimes just added to irritable bowel, which is spastic colon nervous stomach. So so those are just additive to kind of help with the diagnosis. But yeah, they softened up. It used to be very specific how many tender points until a few years ago, and then they redid the criteria. Yeah.
So this is one of those diagnoses that is arrived at through a process of elimination, right? We're looking for all the things it's not before we're honing in on what we think it is.
We want to make sure that we have certain positives, and then we want to make sure there's nothing else that should be treated, like a rheumatoid arthritis or like a high blood sugar that's made you feel crappy for too long, or your alcohol drinking or whatever. Yeah.
Mm-hmm. Okay, that makes sense. Okay, so now that we kind of understand all those basics, what it is, why it starts, how it's diagnosed, let's talk about treatments. Mm-hmm. There's medication and non-medication therapies. Mm-hmm. Do you want to start with some drug therapies for us?
Yeah, the big ones that, traditionally the old days, and this is not FDA approved, but the old days we used to use tricyclic antidepressants. And one of them happens to be a muscle relaxer called Flexeril or cyclobenzaprine. Mm-hmm. So tricyclics, these are old-fashioned Elavil and nortriptyline and dazipramine and imipramine. So those are old-fashioned antidepressants. Okay. Even if you're not depressed, and oftentimes these people are depressed for a variety of reasons, because of chronic pain, or the depression anteceded the pain, which it did in my family. So the depression and other stuff was well before the fibromyalgia ever kicked in. So these people, so it turns out the antidepressants like those can help with the sleep, because they tend to be drowsy. Several of them tend to be drowsy producing, can help with the sleep and can help with the pain. Mm-hmm. And it seems to be the norepinephrine part that seems to be, you've heard about serotonin, norepinephrine, and dopamine and glutamate. So it seems to be the norepinephrine. Why? Because the ones that are FDA approved for fibromyalgia include Cymbalta, which is an antidepressant that has is SNRA, serotonin, and norepinephrine, reuptake inhibitor. So the norepinephrine piece seems to help. So Cymbalta. The other one is called Lyrica. Mm-hmm. Which is made actually from gabapentin. Yeah. Gabapentin is an anti-seizure medicine, and can be used for neuropathic pain and a bunch of other things. But it turns out that Lyrica was, I think, the very first thing that was approved for fibromyalgia pain by the FDA, specifically for fibromyalgia.
Yeah, I think that's what I was reading as well.
Yeah, and then something called Savella, and I can never pronounce it generic, but Savella is another one that's specifically for fibromyalgia and stuff like that. So those are the three big ones that eventually, if people have treatment-resistant, very difficult times, and we'll talk about the non-pill, non-drug therapies. Sure. So oftentimes they'll end up either on tricyclic, which is not FDA approved but very common, or Cymbalta or Lyrica or Savella.
So something I specifically did not hear you mention was opioids or narcotics.
Right.
Why are those things not effective on fibromyalgia pain?
So I'll jump back. Non-steroidals, even though they're not recommended and people say they don't help, I find that sometimes they do help. So non-steroidals, the problem with non-steroidals, and this is the problem with anybody who prescribes, whether primary care or rheumatologist or orthopedist, is that eventually Even if they have FDA approval for less GI upset, less GI bleeds, is that whenever you put people on for months because it's a chronic condition, it's not a few weeks.
Yeah.
So you're on it for months to years. Eventually, these people end up having problems with the nonsteroidals. They'll either it may increase some nonsteroidals have been associated with heart disease. They've been associated with GI bleeds. They've been associated with elevated blood pressure, kidney failure, and retention of fluid. So there's a bunch of reasons that nonsteroidals, even as simple as Motrin, Advil, ibuprofen over the counter, can potentially get us into trouble. But they can be helpful, even though the Rheumatologic Association says.
What about analgesics like acetaminophen, Tylenol?
Tylenol, yes. And so some people, I'm not as big of a fan. I have no problems people trying it. No more than 1,000 milligrams 3 times a day. So that should be a max dose. No alcohol, please, because the problem with Tylenol plus alcohol both can cause severe liver problems.
Absolutely. Okay. So over-the-counter analgesics and anti-inflammatories.
You can try, but I'm not.
sparingly.
It should be for the short term. I'm not a big fan of it for the long term. Yeah.
Absolutely.
The long term stuff is the 3 FDA approved products.
So if in a very severe case, still no opioids or narcotics.
Yeah,
right?
we didn't even talk about opioids. Yeah, opioids. The big problem with opioids, as we all know, and opioids can help with broken bones. They can help with post-op pain. They can help with selected things. Yeah, cancer pain. That's correct. Good. But yeah, this is not, and this is the problem we run into. Yeah, opioids may be used for days, maybe weeks at a time in those more acute cases. But the problem is we're dealing with a chronic problem. Number one. Number two, opioids typically are not thought of for nerve or whether it's peripheral nerve or central sensitization syndromes. Opioids probably tend not to help. Now, people say, well, it helps because they feel a little more relaxed, more sleepy, more tired. But the mechanism of action should really not help nerve pain, central nervous system type of pains.
Okay, that makes sense.
Yeah.
So, is fibromyalgia a chronic neuropathic pain?
Yeah, that's a good question. I tend to call it a central sensitization, so I don't think of it as a neuropathic pain. All pain eventually has to go through.
Can you maybe explain the difference there for us?
Right. So, all pain, everything eventually has to go in the nervous system for our brain to interpret it, whether it's a sight or smell or touch, everything eventually. So what we're talking about is disease of the pathways to the brain. So neuropathy, pathy being pathology or disease or sickness, and neuro being the nervous system. The nervous system, for your longest nerve in your body is from your low back to your big toe, about 4 feet long or so, or 3 feet long. It's a continuous nerve with the cell body in your low back, and so it's that one. For instance, whenever we have alcohol or B12. Or some other autoimmune problems, we tend to feel it in our feet. This is peripheral neuropathy. We'll tend to feel it in our feet first because of that long nerve is susceptible to being attacked by high sugars and B12 deficiency in alcohol.
Okay.
But when we think about headaches, they're part migraines specifically, not all headaches, but migraines. We don't think of it as a neuropathic pain, but it is in the brain. It starts as part of the brain. It starts in the cranial nerve. It comes out in the cranial nerve and stuff like that. So I differentiate those. Some docs may call it neuropathic, but I tend to differentiate it as not more central sensitization of the nervous system, because we technically don't have pathology of the actual nerve. Whenever we biopsy small fiber neuropathy in the feet, we can see under the microscope and with other staining that there's disease of that nerve. But we can't see anything wrong with the nerves, the peripheral nerves with fibromyalgia. I'd have to see if they've looked at the spinal cord specifically in these patients, like post-mortem. You can't biopsy it while they're alive and stuff like that. But fMRI, functional MRI of the brain, in people with chronic pain, including fibromyalgia, is abnormal. So there's no doubt. SPECT scans, nuclear scans of the brain, blood flow, and functional MRI can show changes, not necessarily specific to fibromyalgia, but chronic pain patients. Right. They can see some stuff there that's not commonly used to diagnose people.
Sure. is it possible that, ketamine or any of these other psychedelics or some of these newer treatments that are coming out could have an effect for fibromyalgia? Or are we just not sure?
That's right. We think it does. We think it may be causing some of the remodeling, some of the neuroplasticity that we may see, because ketamine works in the brain and the glutamate receptors. So we think that the ketamine can help. The problem is the chronicity. The chronic problem versus ketamine tends to be more short-acting, short-lived. So it's always a tricky problem to match these the treatment with the disease process. But people can feel better. Certainly, whenever you improve anything, and that's the other things we'll talk about. If you improve their depression, their sleep, improve all sorts of stuff, then the fibromyalgia tends to get better. It may not be cured and stuff like that. So ketamine can help people's depression, anxiety, other things. So we may be. I'm not sure if you just had pure fibromyalgia. I'm not sure if there's anybody that has just pure fibromyalgia. If ketamine would be just good for that, and if they had nothing else to treat that ketamine could treat. Ketamine, once again, would be off-label use for any of these conditions, fibromyalgia or depression. Yeah,
of course. I think that's a good segue into our non-medication therapies. Your point there that, relieving a lot of these things, anxiety, sleep disturbances, depression, can have a positive impact on pain syndromes in general. So let's talk about some of these non-medication therapies. So I know that obviously massage, acupuncture, chiropractic, we think those have some value.
Potentially, yes. Some people it just hurts to touch their skin.
Sure.
Some allodynia, some hypersensitivity of stuff that's not painful. If somebody touches your skin lightly to massage, it's not typically painful for the rest of us. But for these patients, even putting a blood pressure cuff on and squeezing it is enough to make them cry out.
Yeah.
So it depends on what level. But yes, that's absolutely right. Acupuncture, it's not been studied. We don't have as much data, but the quick answer, certainly there's no negative side effects whenever you have acupuncture or massage and stuff like that. Yeah.
Gotcha. So another big one is cognitive behavioral therapy and mindfulness. Can you talk about those techniques?
Yeah, yoga, everything from yoga to everything. This is because a lot of these people have depression. A lot of these people have sleep disturbances. And a lot of these people have had to alter their life, their relationships, their work, their responsibilities. So CBT, cognitive behavioral therapy, to help you deal with your life changes, both chronic pain and all the fallout from the chronic pain. Yeah, it alters these people tend not. It hurts to exercise. It hurts whenever the freaking weather changes. Yeah. And it's the old-fashioned rheumatism. When grandma wakes up in the morning, they can feel the rain is coming. Well, certainly people with old osteoarthritis of the knees and people with rheumatoid arthritis will feel sometimes the barometric, the electrical changes in the atmosphere. The barometric, called pressure, but sometimes it's electrical changes. Migraines can sometimes with weather changes. It's not so much barometric, but electrical changes in the atmosphere. But these patients. So a lot of people, quote unquote, their conditions act up. But this is certainly one of them. And just plain weather changes is enough. And so these poor people, unfortunately, wake up and it's going to be damp. They hurt. And if they try to exercise, it hurts. And if they try to just do their activities of daily living, it hurts. And they have to go rest a lot. They have to go take a nap and sometimes rest. And so it's very frustrating. So gentle exercises. The traditional teachings is warm water. The idea you don't want to be pumping iron. You don't want to be cold. Warm water exercises. So warm pool. Good luck finding a warm pool. But warm water exercises tends to initiate and eventually gradually, with the help of a trainer, a physical therapist, other people, work your way up. Because a lot of these people become deconditioned because it hurts to move.
Right. So I want to say just a little bit more about CBT and mindfulness. Obviously we know this from our experience with mental health and how this works for patients with depression and anxiety and other conditions. But I can imagine that, a big part of CBT is language, right? Is being able to describe what the trigger is, describe the feeling and the emotion that you're experiencing.
Yes.
And having that language and being able to say and name what it is helps to kind of put the problem in its perspective and in a box.
Right.
And then once we can name and explain what the issue is, then we can come up with coping mechanisms that help to deal with it.
Yes.
And then additionally with mindfulness, that's about like kind of being able to drop into your body and stay in the moment and be aware of what you're experiencing in that physical moment. again, if you were talking about this before, that just that general feeling of malaise where everything's bad, everything hurts, that can kind of balloon into this all-encompassing thing that kind of controls and colors your whole experience.
Everything's
how you
gray.
think about
Right.
yourself, how you feel on a day-to-day basis.
That's right.
And so kind of, building up some of these skills with CBT and mindfulness can help to at least help the patient feel more empowered, that
Yes.
they have some control over how this works in their life. So,
Well, it's important for them to recognize that when they had bad low back and had depression, that was one thing. But somehow they think their life has gotten worse, and it's not necessarily because of depression and bad low back, but because they added fibromyalgia. They just slipped in under a cover of night type stuff, and it takes a while because physicians, nurse practitioners, PAs, whenever people say they feel shittier, you'll ask, well, in what way? I don't know. I just can't
Yes.
sleep in this, and so
Yeah,
they'll
yeah.
treat those sleeping, they'll treat this,
Right.
but they won't kind of figure out that this is fibromyalgia that's attached to all these new changes that the person says is just feels crappy,
Yeah.
and in which case, accidentally, oftentimes you're treating them with antidepressants anyway.
Yeah.
Maybe not the SNRIs or the tricyclics, but you're trying with the SSRIs, which can help a little bit, but it's not as good as the SNRIs, the Flexerils, the muscle relaxers, part of the tricyclic family, the Lyricas and the Savellas, et cetera. Yeah.
it's interesting that some of this cognitive training can actually help you, or it seems like it could actually help your physicians and your caregivers
That's
treat
right.
you more accurately if you can really, if you're very
Express.
in touch with how you feel and can
Right.
express how you feel
Right.
in specific ways.
Yeah, just this morning, it was not fibromyalgia, but this morning I was talking to a patient who's severely depressed and anxious about, whenever he says, I feel like crap, for him to journal it,
Yeah.
so that he, like you said, that he uses his words, and because whenever you read your own journal, you read your own stuff, it comes back to you. Nobody's telling you, like
Right.
6 months ago you said this, it doesn't sound right. But whenever you read it, you're like, this is how I was feeling 6
Yeah.
months ago, and I'm back feeling that way again. What
Right.
happened? So, using words, and that's we see this in a lot of people, a lot of depressed people, but even men in general with anger issues, all sorts of stuff. They just don't know how they can't use their words,
Yes. Yeah.
even though they're quite intelligent and et cetera. Yeah, their ability to put it into words, which, like you said, kind of puts a fence around it, so it's
Right.
not this all-encompassing fog of crappiness in
Yeah.
your life. Yeah.
Exactly. It kind of takes it from a visceral, uncontrollable reaction to something that can be explained
Right.
and therefore coped with.
Right.
Okay, great. I love it. So let's talk a little bit more about exercise and then self-care. And I think with this talk about exercise might be a good time to bring up that connection to chronic fatigue syndrome and how
Right.
this building of your capacity to, withstand fatigue or periods of pain helps your recovery period to not be so long. And that's something that we can do through exercise for fibromyalgia and for chronic fatigue. So can you talk a little bit more about that?
Yeah, chronic fatigue came out many years ago as just a CFS, chronic fatigue syndrome. It's been renamed. As myalgic encephalomyelitis, which is a horrendous term, but it's more descriptive.
say.
But it's the same thing as CFS. So it's called ME, or myalgic encephalomyelitis. But many years ago, we thought that these people who were just chronically pooped, they didn't know why. Oftentimes they were depressed, and sometimes they had aches and pains, and we just called it that you were depressed, and we put them on antidepressants. Some of them got actually better, but then we made a correlation with CMV, which is not CMV, EBV, Epstein-Barr virus. So that these people post-viral infection just would have the stuff that knocks you out of high school, or kissing disease, the mononucleosis. Epstein-Barr virus is the mono. So some of these people would have bad cases of it. Doesn't always, where you'd have to miss school or miss college for a semester or whatever because they're so fatigued. And so that was the other correlation. But eventually, there's probably a bunch of causes, including the association with fibromyalgia syndrome, so that we think that it may be the same disease, but just different manifestations. It may be the same central nervous system hypersensitization central sensitization of pain, central nervous system sensitization to pain, and fatigue is part of that continuum of pain and fatigue, and sleep disturbances and stuff like that. So it may be the same condition. but just kind of shows from just your different part of the elephant. Somebody's feeling the trunk, it says this is the elephant. The other person's feeling the tail, it says this is the elephant. Both of them are both the same elephant, same disease, but you're just different perspective of the same condition. And there's a very interesting correlation with something that we've talked about briefly in the past, called MCAS, mast cell activation. Mast cell activation syndrome. So this is part of the inflammatory. Once again, this is part of an autoimmune. It's a part of the immune and infection control white cells. They're called MAST, M-A-S-T cells, and there may be a correlation with that. Why? Because it turns out if you some people, we can use low dose naltrexone, LDN. Naltrexone is that stuff that blocks narcotic overdose that we give people. But it turns out so there's naloxone, Narcan, and naltrexone, whatever, Vivitrol. But Narcan, thank you. But at low doses, instead of 50 milligrams like Narcan pills, you can use like 2 or 3 or 4 milligrams, so they're kind of specially formulated at low doses that you could help people potentially with MCAS and with chronic fatigue and with fibromyalgia. So that one treatment may cover several conditions. So there's some very cool stuff out there about that. Once again, these patients end up with a lot of complementary alternative medicine, whatever you want to call it, integrative medicine, because they feel like crap. They're losing time, energy. They're losing time, money, and so the physicians don't know what else to do with them because, of course, all the tests are negative or normal, or we don't have a way to test for all this stuff. So they end up, on the internet, anything with chronic conditions, whether it's multiple sclerosis or chronic fatigue or whatever, they end up on the internet looking for people that'll listen to them or give them vitamins, something that'll make it help because they're pretty desperate.
Yeah, absolutely. So, I mean, a lot of this comes back to the, some of this self-care and lifestyle factors. I think it's interesting that, for, like we were saying, for fibromyalgia and chronic fatigue, to avoid that breakdown of the body, you can, if you're in pain all the time or if you're tired all the time, your tendency is to just want to rest and limit your activity in every way, which causes even more fatigue. It kind of piles on. So exercise is not necessarily to help the pain go away, as just like it's not to help the fatigue go away, but it's to help to kind of keep it at a baseline manageable amount to where your body can actually recover a little bit.
That's right. Some of these patients with fibromyalgia without chronic fatigue have a hard time climbing the stairs because they feel exhausted. And this, by the way, this is the same thing whenever people have mono or whenever they have the flu. If they're otherwise healthy and get mononucleosis, Epstein-Barr virus or influenza, they're climbing the stairs feel like they have a heart condition.
Yeah, absolutely.
And a couple weeks later they're fine, but it feels like you have lung heart problems. Literally, you feel like there must be something wrong with me because they're all over tired. It's not just their breathing; they're all over exhausted. And so same thing with these fibromyalgia patients. So we do have to check, and especially with women, we do have to check that the fatigue going up the stairs and stuff like that is not a heart condition.
Sure.
Because they have silent ischemia, silent cardiac problems. So we got to be careful that we just don't brush everything under the same carpet, but once again, it racks up a bill. But you have to do these things to check them off to make sure that now we can focus on the fatigue and the fibromyalgia piece of it. Yeah,
absolutely. So let's finish up with self-care. I know that things like, so for fibromyalgia patients specifically, sleep hygiene. So coming up with a really good sleep schedule.
That's right.
Doing, making sure there's no sleep apnea or anything that's interrupting the sleep as well too.
Right. They end up with a sleep study doctor. That's correct. That's a big deal. By the way, children, you can imagine if it's adults who have a hard time understanding this, you can imagine if a youngster has this type, these stuff that I just listed, and they can't make it to school and they can't do sports. People think that they're lazy, they're goofing off, or they're, being oppositional. But this is, and unfortunately there's no test to prove whether they're faking it or not. Yeah. So this is a difficult diagnosis to make on adults, let alone youngsters.
Yeah, absolutely. So, sleep hygiene, making time for rest and relaxation during the day so that you can minimize physical and psychological stress.
Right,
so stress can be a trigger for onset. It can be a trigger for worsening. Correct?
That's right. Exacerbations.
Yeah.
Right.
Okay. Well, how have you seen this play out in your patients? Have you seen fibromyalgia come in your patients?
Oh yeah, of course. Yeah, one of my like I said, my mother, I have it. And one of my patients, she came to me in the very first session. I said, "You have fibromyalgia." I put her on cyclobenzaprine or Cymbalta, and it literally the next visit, it's like, "Oh my God, this is the best I've felt in years."
Wow.
So sometimes it's that dramatic.
Yeah.
So it's not cured, and she needed to do a bunch of other non-pill things to help herself out. But it's you can, like anything in life, if you people to name it, like to listen. Number one, to be heard and not to be poo-pooed, brushed off. Number one, to be listened. Number two, to get an accurate diagnosis. Number three, to talk about everything from the psychosocial to the financial to the medication to non-medication to family. This is always the issue with any chronic condition. It doesn't matter if it's this or depression or alcoholism, is that it involves other people in their life.
Right.
Yeah.
Absolutely. So, if anyone's listening to this and they think that maybe this might fit the bill for them, where would you suggest they start?
Yeah, it's always with your primary care doctor. You can keep a little log about kind of how you feel for a week or two, and things that you remember that may exacerbate it. And see your primary care physician. Let them know if you have a family history. Make sure that the primary care doc or nurse practitioner or physician's assistant is able to make sure the physical exam, make sure blood work is basic blood work. It doesn't have to be very fancy. Basic blood work, one time round of basic blood work. Certainly if there's red flags, you're having fevers or chills or abnormal weight loss or loss of appetite or other things, so you have to make sure that that's not just fibromyalgia by itself. Obviously, there's something else going on. And then all the stuff that we talked about, both the non-pill therapy, lifestyle treatments, and then medications, and being able to communicate with your doc. Sometimes these patients end up at, depending on what, they end up at the urologist if it's a bladder issue, the gynecologist if it's a menstrual issue, the rheumatologist if it's just they think that it affects their mobility, orthopedist et cetera, sleep doctor and psychiatrist. So a bunch of different people can touch one person depending on how the person presents or what the patient complains about. Complain is a positive term here. So
sure.
Complains of is a technical term for us. They're not moaning. They're just telling us. Anyway, but primary care doctor is typically the first thing, and you want to and you could collect the data for them. You say, hey, I've been on antidepressants. I came off of it. I'm going through a rough time, and I had poor sleep, and I'm worried about this, and my mom has fibromyalgia. You could help piece it together for the practitioner.
Yeah, absolutely. We always want to leave people feeling, hopeful, like they have a sense of agency, that there's something to be done about this. Fibromyalgia is another chronic condition that's very common that a lot of people deal with, chronic pain in general.
Yes.
And there are certainly lots of resources out there and a lot of awareness in the medical field of these kinds of issues.
That's right.
Well.
In the old days, we used to think that it was quote unquote in your head.
Yeah.
Like I said, it's the association with so many other things that are difficult to diagnose and treat, and it's very real. Yeah.
Absolutely. Well, thanks so much for doing this one
thanks.
with us today, bringing the topic to the table, Dr. Tadros.
Thanks for modulating me and for moderating.
As always, if you would like to get involved with the pod, you can send us an email at notyourdocpod@gmail.com. Our website is forthcoming. That's going to be notyourdoc.com. Seth has been hard at work on that for us. It's going to be a central location for Dr. Tadros' blog as well as our podcast. You'll be able to listen to all the episodes there and get links, same that you would, on YouTube or if you follow us on Facebook. So lots of exciting stuff going on. Thanks so much, guys.
Thank you.
We'll see you next time.
Bye-bye. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.